and I think a lot of students try to outthink the scenarios, and it's really based on experience that you've experienced during clinicals, during ride outs, and if you've worked as an EMT, you understand this stuff. If you've worked in the 911 system or respond on an ambulance, it's all the stuff you do without even thinking about it. Does that make sense? Especially like the pre-scene stuff and everything like that. So this part, I'm assuming you're Sarah? Sweet. All right, what do you work at?
I work in Venus, but they on-called me to Kaufman, so I hate my life.
Oh, I don't blame you. You work at Venus? I live in Makepearl.
Oh.
Yeah. You were running into, oh, shit, he's a lieutenant out there. His dad's a chief in Midlothian.
Brancato?
Brancato.
Oh, yeah.
Yeah,
I worked on his
Blake.
shift.
Okay. Yeah.
Well,
Blake's good people. Didn't think that long ago I was hoping to get past his registry here. All right, so I usually write down like a breakdown of your test. I can tell you right now, the old breakdown is way different. This part of your test, the clinical decision making, is about 57% of your test, or so close to 50% of your test. You will get scenarios that are anywhere from 10 to 15 questions long. What you have to pay attention to is the first part of the scenario will be the en route. They will give you a set of dispatch information, and it will be the en route, and you will have so many questions. It doesn't make a big Broadway announcement that you have switched to scene. So you have to pay attention to the information at the top. If it changes, now you've moved to scene. And scene is a whole different list of priorities. All right? And then you get post-scene. Post-scene is everything leaving the scene until you get to the hospital. So all this is that, all this there. I will say, if you're wondering, like, hey, the load and go method, give them a shot of diesel, that only applies to certain scenarios. When would be a good time, like, hey, we need to go and do the treatment en route? When's the time when we need to make good time? Trauma. All right, now, do we need to stabilize some things before we take off in trauma?
Yes, sir.
Yeah. And we'll go through that in the operational order, treat life threats, address any AB. This is pretty much on trauma. You take care of this stuff on scene. All right. Another thing would be stroke. Right? You got to kind of meet a time frame, right, to get them there. But you also have to look at what's the most important thing in stroke?
What time it happened?
Time of onset. So if you get there at 30 minutes after it happens, the onset time, you got some time, right? You don't have to. Yeah, right. But if you're at that 2-hour, 30-minute deal and the stroke hospital is like 45 minutes away or 30 minutes away, what do we need to do? Try to beat that 3. Sometimes it's a 4-hour window, depending on what kind of hospital it is. But you try to make that window. So you have to factor that stuff in. It's stuff that you've learned throughout the deal. Like, hey, what happens if we're 2 hours in like that? Then we probably need to do some of our stuff en route. Now, can we do an assessment and do a 12 lead pretty quick?
Yeah.
Yeah, you can do that stuff. It doesn't take 20 minutes to start an IV or something like that. But it's just factoring that stuff in. Just say, hey, really, how long does this take to do? All right. Trauma, we definitely need to be inside that, what do they call it, Platinum 10 and all that other stuff. So I would say lean towards, if you can do stuff on scene, do it, but pay attention whether it's critical needs or, and if it's a stable patient, like just a run-of-the-mill call, I would say do everything you can on scene. Sorry, I forgot my little notification deal still on there for work. Another CPR. We killed a pair. Oh, we didn't kill him. A car killed him, but we ran on traumatic arrest yesterday. He was a para-Olympic gold medalist, multiple gold medalists, something like that. It was on social media this morning. I was like, oh, that's the dude that got hit by a car. I turned it off because one of the if we get structure fire, that alarm that comes on, it scares the living shit out of me. Alright. So this is you can have anywhere from maybe 4 to 6 scenarios. I have some stock scenarios that they've used before, and we will write those up there at some point and go through any questions I ever get. I always keep them and write them down so that way you see it. Like it could be. I might talk about some of them. So the different style of questions, real quick. You can get the pick 3 out of 6. So pick 3 out of 6 could be pick 3 diagnoses based off what you know so far. Vitals, chief complaint, whatever. It could be prioritizing what equipment you're going to take in. It could be prioritizing. You could get ones that are like, I can't remember if they do high, low, or high, medium, low, but let's say high, medium, low. You might get a question like, let's say they give you this. Let's go ahead and use me. 47-year-old male with chest pain. I'll give you the OPQRST. Onset, 30 minutes. Occurred, let's say at rest. Quality feels heavy. A little bit of pressure. And radiation, no radiation. Severity, let's say it's a 7 out of 10 times 30 minutes. All right, and they give you a set of vitals. Let's say 160 over 80. Heart rate's 94. Pulse ox is 93%. And EKG lead 2 is sinus attack. And let's say blood sugars, 110. Respiratory rate is, let's say 20. And it gives you a bank of 6 diagnoses. So let's say, and you got to place them, so you got to put 2 of them here, 2 of them here, and 2 of them here. This is, if you're looking at doing this for a diagnosis question, to me, the high or most probable, I guess it's most probable, that's what it says, but I'm just doing high, medium, low. You get what I'm saying, right? The high or most probable one is going to be ones where multiple signs and symptoms are matching and there's nothing to contraindicate. Does that make sense? Mm-hmm. Medium or, could be probable still. It has some signs and symptoms, but it may or may not be. All right? Low is there's definite contraindications, something that doesn't meet. So they'll give you a bank and it'll say, let's say it didn't happen at rest, at sleep. So let's say your 6 choices are costochondritis. I'm probably spelling it wrong.
What does that mean?
I'll get to it here in a second. We're going to give you a temp. By the way, on temp is a very important vital sign. All right? Now, they're not going to give it to you in Fahrenheit. They're going to give it to you in Celsius. What's a normal temperature in Fahrenheit?
96.
986, right? That equates to roughly 37 degrees Celsius. So you need to equate anything greater than 37 as fever. Fever means infection. So infection means it needs to be an infectious process as part of your diagnosis. You know what I mean? All right. So pneumonia, And you can put chest pain, shortness of breath. Pneumonia, pulmonary embolus, MI, uh, there we go with bronchitis, and, alright. So you got those 6 up there, and you're trying to figure out which one is most likely. Alright? Now, have you already picked your too high? Just off that list. Like common sense, 47-year-old, I know I got chest pain, 7 out of 10, shortness of breath. By the way, the temp is, we'll say, 36.8. Let's say 92 or something like that. Alright? So, just off that information, what do you think your number 1 is?
MI.
Alright, good. That is correct. Alright, so MI goes off the list. Alright, what's your next closest? Alright, so MI, are we meeting multiple signs and symptoms? No contraindication? Alright, PE, is that chest pain?
Yes.
Can we call that acute onset, 30 minutes? Alright, shortness of breath? Alright, so far, we can't rule out PE, right? So PE is your number 2. Alright, now, this has some of the signs and symptoms, but may not have some critical ones that we need. Alright, what would you do? Oh, by the way, costochondritis is, are y'all any big fans of like picking words just because you don't know them and thinking, not confident in it, and you're like going, well, I don't know this word, so this must be the answer.
I did the opposite.
Do not do that.
Oh, thank God.
Alright. Do not pick the big word just because you don't know it and you're afraid that if I don't know it, that must be the deal. Here's how you get to, when you get to that scenario, you need to try to, I will never do that unless I can eliminate the other answers. If I can eliminate B, C, and D and go, okay, I don't know that one, but I know it's not these 3, then I'll pick that one. But don't pick the big word because you're nervous or something like that and you think, oh, you're not confident in yourself. All right? If you don't know it and you can't figure out the word, don't pick it. That's one of the words students came back to me and said, hey, what is that? I go, it's literally like pool muscle. Like, you would expect this if they were doing athletic activity. Like a guy guy goes and lifts for the first time and he hasn't lifted in 3 years. You know what I mean? Like the January 1st, Warriors, New Year's resolution. He goes in there and you go do all that, like I'm gonna do, back in high school I used to do bench press and goes in there, I'm just gonna do bench press max and do all this chest stuff and everything like that, and wake up the next day and feel like your chest just is about to explode. That's costochondritis. It's like stretch muscle. All right. But it's all in your chest.
Did I give you the lung sounds as well?
We'll go, no, let's say they didn't give you the 1 cents. All right. Now, okay, I'll give you 1 cent. Press sounds, clear, bilateral. Now, did you just figure out one of your low priorities?
Yes, sir.
All right, what is it? What if I did this? Breath sound, diminished, lower. What does that little change do to you?
Bronchitis goes higher.
Bumps bronchitis and pneumonia up, doesn't it?
Yes.
All right, so you're sitting there going, oh, okay. Low sat, like that. So that could change the whole, one little deal can kind of change it. All right, but it can still eliminate tension pneumo, right? All right, so breath sounds will stay clear bilaterally. That knocks out tension pneumo. All right. Now look,
The one.
Yeah, you got
Yeah.
Costa Drive?
Yeah.
I think it's spelled like this. CH. Alright. Now, lead you with pneumonia, chest pain, shortness of breath, low sat, clear breath sounds, but guess what? He meets some of the criteria and a normal temp. So it's like that. Bronchitis, kind of the same way. But for sure, I think I can eliminate those. That's how you do that.
Another question. Does it matter which order we put them
Yeah. That's the whole deal, is putting these in order. That all this 6 answers is one question. All right. Now, you might get a question too that says, we're going to prioritize equipment. All right. So you get that would be a diagnosis type question. You get, say you're going to prioritize equipment. And I'm trying to just give you examples before we get into this and say, okay, you're going on a, let's say, suckers, sorry, let's say you got a 70-year-old male, fall 10 feet, ANO times 4. You got a EMR at scene. So you got like emergency medical responder at scene, and he's the one giving the information. So, and you got a head injury. Let's say hematoma with a lac. All right. And that's all they'll give you right now. And it says you're responding to the scene, and it says you got 6 pieces of equipment. You got your IV bag. This is at a football game. You got your IV bag, you got your airway bag, you got a tourniquet. What's the thing you put on a femur fracture?
Traction
splint. You got traction splint. You got your monitor. And, sorry, airbag, airway.
Trolley bag?
No,
No.
IV bag,
Suction.
airway bag, tourniquet, traction splint.
Oxygen canister? Wouldn't that be?
No, that'd be with the oxygen. It was a backboard. This is a legit question. Alright? Now, you have to prioritize your equipment. It's going to be the same thing. I'm using high, medium, low because I can't remember what to do. Based off just that information, which information is, you're carrying equipment, you're prioritizing, what you're for sure, this is, for sure we got to have this. I know I'm probably going to use this. I know I'm probably going to eventually use this, but it's not the first thing out of my toolbox. This is, I'm probably not going to use this on this patient. All right, which one can we figure out first?
EKG backboard.
All right, where are you placing those at?
Backboard, I think high. Yeah.
Does everybody agree backboard goes 1?
Yes, sir.
Yes. Backboard definitely is like one of the main things we're carrying. All right. Where do you think tourniquet goes? Did I meet any indication for a tourniquet? Just based off, I got a medical person on scene. Did he say bright red blood spurting from his femur? No. So probably not going to use a tourniquet. So we'll put that on low. Didn't say anything about deformed leg or anything like that. So, traction goes down here at the bottom. So, I know for sure, like, this is where like when you get to the pick three and stuff like this, the first two answers are pretty obvious. The third one, you have to think about it, but don't outthink yourself. Use common sense. You realize that right off the bat. But you can't add any hot sauce to the question. Can't add hot sauce to your meal. You take it the way they deliver it. They give you a ham sandwich, you're getting a ham sandwich. You cannot play the what if game on this test. Yeah, but what if, what if, there's a terrorist on scene and he's released VX gas? No, they didn't say shit like that. There's no clue to say there's a terrorist on scene with VX gas. You cannot add stuff to it. No ranch, no mayonnaise, no hot sauce. It's a ham and cheese sandwich, plain and dry. That's what they give you. Don't add to it. Don't say, what if he's a diabetic? You don't know that because they haven't given it to you. Because I might need to put IV up at the first and go, well, he could be a diabetic. No. Do not play that game with this test. I'm telling you, it's easy to get in that loop. Don't do it. All right? I know I need a bet. All right? Now, prioritize what's next.
You can hear me?
Where do you want the monitor at? Why do you want it at the top?
No, you can check for the blood pressure, check O2, 12 lead, but blood pressure.
Do we usually do 12 leads? High priority in trauma?
No, sir.
Yeah, you want to do a 12 lead because you might do a 12 lead because he's what? How old?
70.
Or you might put him on a lead 2 because he's 70. Who would have did that? But it's not the first thing we do. So the EKG actually goes here. Will we eventually do that? Yeah. All right. Look up there. What does it say? C-spine, airway, breathing, life threats. That's your priorities in trauma. All right. Guess what? Airway back. Airway kit. I think is what we said. Now, will we start an IV on this guy? Yeah. We'll do an IV and EKG. But that'll be secondary. You know what I mean? This is my primary stuff. That's your primary stuff on operational order. You take care of life threats, airway, breathing, circulation, especially on trauma patients. What you got?
So even if they didn't get it, they're going to follow the.
Huh? Yeah. But this is verbatim, like the question. It was a 70-year-old at a football game. It's a whole scenario that I have written out. But I just want to give you an example of that style of question. All right? Now, I may give you another one. We'll give you like we'll give you an en route type deal. All right? And it says you're en route to a medical emergency at an apartment. It's let's say 11 p.m. It's raining. Let's say 46 degrees outside, and and it gives you a list of 6 things, and this is en route. 6 things that you want to know or want to take care of while you're en route. All right. Let's say medical emergencies for nausea, vomiting, and it's a let's say 57-year-old female. All right. and you're at MICU with 2 paramedics, and you have a EMT engine going with you. So 3 EMTs on the engine. I think it's just the sign. And institution assignments. When you talk about assignments, like, think about this. Parent equipment. Assign roles, patient initiative, and that's the PD. And it says, what 3 things do you want to do or want to know en route to the scene? This is all you got. Medical emergency, 57-year-old nausea vomit, typical medical emergency call. You got MICU, you and another paramedic, and you got a engine full of EMTs, 3 EMTs. You're going to an apartment complex. It's 11 p.m. at night. It's raining, and you got it's 46 degrees outside. And it's saying, basically, you're en route. What do you want to know? What do you want to know or do before you get there? And it's going to say, what are 3 things? Pick 3 of the 6.
Vital signs.
All right? Tell me why that's wrong.
They're
They're not on scene.
Oh.
Do we ever ask dispatchers for vital signs?
No, sir.
No. Do we ask them to give a patient history?
No.
So you have to think about it from the around. I'm using it
Oh.
because people will do that and they go, oh, because whenever y'all do scenarios, you're like, hey, what are his vitals? What is this? I want you to wrap your mind around that en route is anything you would get from dispatch. All right? Or you communicate with the crew. So we're not going to do this and we're not going to do that.
Access to patient.
You have to put yourself in, know that you're in the en route section. All right? Because you will fall into that. You're not doing anything anybody else hasn't done. That's normal. Because you're used to it when you do scenarios. You're like, give me the vitals, give me the vitals, give me the history, all that. We don't ever ask dispatch for that. We just ask dispatch for those things over there. All right? All right? Now, you got to get 3 out of the 4. Which one goes away? Is there anything that says we need PD here?
No, sir.
No. We need to know access to the patient. What could that mean?
What floor?
What floor? What's the apartment number? Is the door open? Do we know the gate code? You've all ran on the apartment complexes, haven't you? You have to put yourself in that mode and go, okay, like I did this the other day. I was the last one. I have to drive all the way to the 11th district, and they have nothing but those residential over commercial. And it's like a big square. They call it Times Square. I gotta know the access point. And I asked them, I said, hey, I was like, they're on scene. I said, I don't know the apartment numbers offhand, because it's not my district. And I said, hey, and I'd be able to see this, because I see where the engine is, I see where the medic unit is. By the time I show up, I'm the EMS supervisor on shift. And I sit there and go, hey, which one are y'all making access to, the south entrance or the north entrance? All right? Because they're going to make access to the closest to the apartment. You know what I mean? Because some of those are just tricky. But that's stuff I want to know. Access to the patient. So, access, that can be gate code, apartment number, door open, all that other stuff. All right? So, we got that. Assignments. So, have you ever been to a call to apartment complex in the rain?
Yes, sir.
what's the smart thing to do?
Keep everything dry.
Take everything. Not everything like backboard trauma, but take the EKG, take the red bag, or, all that. Take the stuff you think you're gonna need. If you were going to a seizure call in an apartment complex, common sense would say, hey, everybody has a narcotics box, right? Hey, open it up, take the narc box. Because what's in the narc box? Stuff to stop seizures. This is stuff y'all do. You just have to think about it on this test. It's common sense. Like, you taking the narc box in with you. If it sounds like I need the narc box, hey, if it says, hey, you got a broken leg up on floor 3, I don't want to have to send somebody all the way back down to get narcs and then come back up. Take the narcs with you. It's stuff that you already do. You just have to put yourself in that mindset for this test. Does that make sense? That's why I say it's common sense. Put yourself in a call at your city, at your work job, at your clinical ride-outs and stuff like that, and do the stuff that you've seen others do that's just second nature to us. And then assign roles. We do this all the time. Y'all wrote that fire department? All right? Hey, if we show up on some calls, we take just a bag. What do we ask the engine to do? Grab the stretcher. You know what I mean? So when they say, this is all part of crew resource management, they're big on this test. Hey, pre-assigning roles, pre-assigning who gets what. That's all they're asking you to do. It is stuff that we do second nature without thinking about it. But our second nature is called crew resource management. All right? Hey, have them get the stretcher. Hey, I want y'all to do this, do that, like that. That's crew resource management. So that would be your assignments, and roles. All right? But that's game planning. This is all en route stuff. Only based off dispatch information. Like if you were headed to an NBC and they come to initial information says 2-car, and then they go, hey, PD's on scene and saying, now you're getting intel as you're going to the call. They say PD's on scene and saying, hey, it's a 6-car wreck. You're en route.
Get more resources.
Good. So, gets us to this. En route to the call. All your en route choices is going to have to be with safety. All right? So, do you need PD? What would be have you been on calls where you had to call for PD? All right. Did you call for them before you got there? I know you work in Venus. You got to call for PD sometimes. You're en route
They're
to.
usually already there.
You're en route to the trailer park, and for a lag to the hand, or they say, or sometimes you can hear them on the phone still, and it says, hey, they're sounding real aggravated. There's a lot of yelling on scene. I say, you know what? I say, call for PD. I said, we'll stage till PD gets there. And you stage a couple blocks back or half a mile, whatever, but you stay away from the scene. We've done that before. That's what you do. That's what you use PD for. What else could you use PD for? Traffic. Block traffic. If it's on a highway and stuff like that, and it says just like that, you want some kind of resource. Fire department, extra engine, extra truck, call for it. That makes your scene safe. Where are we at the most dangerous or vulnerable spot at in our careers? You may think inside a burning building. No, it's on the fucking highway.
Yeah.
Yeah. And if anybody's never had an experience, I promise you it'll scare the shit out of you. Because somebody is not paying attention. So when you have someone having a blocker, yes, have a blocker, have PD block. There was one time I could not get out of, I'm driving the truck and I made it so my guys could get out on the right side. I could not exit the vehicle because they were coming down off the deal onto 121 and they were coming like 70 miles an hour. And I could not, I get like just one after the other, and like nobody gives a shit. They were like swerving last minute. I had to jump over the doghouse eventually and go out on the captain's side. That's what happened. So call PD, make sure everything is safe. All right, let's not think of a wreck or a PD issue. And this is something you might not think about. I didn't think about it, sis. I got the question wrong. And I came back and I go, and by the way, you can tell when you answer these, sometimes you can tell if you got the previous answer wrong or right. Hey, if you missed one, you missed one. No big deal. Just like I tell my son in golf, you can't fix that last shot. All you can do is be present and work on this shot. All right. So it said it was a breathing difficulty. It was a 75-year-old male, second story. It was in a townhome, second story. Wife said the door will be open. It's raining. They give you all this other stuff, and it says the dog. There's a dog in the house. I said, what do you do? All right. It says it was like those pick three. It's like, what are you worried about, or what do you want to take care of? I didn't put the dog because I assume I have a little yappy dog, and everybody has a little yappy dog. I want you to assume that every dog in this test is a ferocious killer, and
It's
you
Princess.
need to take care of it. Yeah, you need to take care of Princess, the ferocious killer, or the beast from whatever. But if there's a dog on scene, all you got to do is say, have the patient take care of the dog, kennel the dog, tie him up, whatever. Just get rid of him. All right. But that's another deal. You're making it safe to approach. But anything you can do to make it safe, based off dispatch information. So they're giving you intel, use it. All right. The other deal, resources. We just talked about that. What resources do you need? You got to remember, how many of y'all work for a fire department? You are not a fireman on this test. You are a working for a private ambulance, and you're either a basic, you're a paramedic with a basic, or two paramedics on an ambulance. That's it. So if you need hazmat and you're a hazmat tech, you're not a hazmat tech on this test. You call fire department. If you need rescue and you're a rescue tech, you don't do that on this test. You call fire. Extrication, no. You call fire department. So that's calling in your additional resource. If it says patient is pinned in vehicle, then guess what? We need fire department to unpin them. Does that make sense? Like, you're not carrying extrication equipment on your fictitious ambulance. All right. So resources could be fire department, could be PD. Trying to think. You could need an additional ambulance. Get the 6-car wreck. Hey, give me 2 additional ambulances.
Air.
Huh?
Calling for air.
Yeah. You could need air. All right. I will tell you this on air. You have to. How many of y'all have experience calling helicopters? Are helicopters fast?
It takes like 7 minutes to prep.
It takes 10 minutes to spin up.
Yep.
It takes 10 minutes or 5 to 10 minutes to land.
Yep.
Y'all probably had them out here for MCI, right? What they do? So that's every scene. It takes a minute to land, then they have to wait to power down, and then they get out, and they have to make contact and all like that. It is not a fast deal. Now, if we were in Corsicana, and the closest trauma center is our way, yeah, they fly a lot of people out of there. It makes sense. It buys you time. Versus ground pounding, which would take an hour. All right? Because it'll take 30 minutes to get to Wilmer and another 30 minutes to get to the hospital. And usually Big Baylor's their hospital of choice. So you have to look at the scenario, but you also have to realize that, hey, flight time, they may say flight time's 20 minutes. But you got to say, hey, 5 to 10 for spin up, 5 to 10 for coming to scene, 5 to 10 to spin up again. So you have to factor that in the equation. I would say the almost go-to on this test for using flight would be, and you have to recognize it, say, all right, let's say you're going to let's say it's here in Waxahachie, and the closest trauma center is Midlothian. And you go to Midlothian with all your traumas. You don't usually fly anybody like that, but you're responding to DART, what do they do, the cups?
Yeah.
Yeah, DART plastics, DART whatever it is. You're going to DART. And a guy has his arm caught in a machine. To you, that has to translate to, that's a prolonged extrication. So anytime somebody's extremity is caught in a machine, that's a prolonged extrication. That's a great time to have, because you can have them landed and everything, because they're going to have to disassemble that machine, turn the power off, do all this other stuff to get it out, just assume it's gonna be a long extrication. All right, so prolonged extrication is a great time to call for air resources because you can have them on scene, ready to go, right when you free them and get them out. Does that make sense? And also they can have blood too, you know. All right, so weather. Believe it or not, weather is a huge factor on this test, and they rely on your common sense. That 70-year-old at the football game, in that scenario, it's 30 degrees outside. All right, trauma patients, do they do well in the cold?
No, it's not.
They need to need heat, right? Because what happens in the cold? Even if he had other major injuries, guess what? They bleed easier because it affects their clotting cascade. All right, so they bleed easier. They can't clot as well. Like that. Trauma patients, trauma rooms, they all need warm. That's why if you go to a trauma room at the hospital, you're sweating. All right, that's design. You need to heat up your ambulance. You know, we give warm fluids now. We give blood and we heat it up to 100.4. You got it. They need heat. So 30 degrees, use your common sense. Do you want to be sitting out there in 30 degrees treating for 20 minutes? No. Treat the common sense stuff real quick and get them to the ambulance. All right? So just factor in that weather and say, okay, now if it's, you're not going to call for, all right, by the way, do you call helicopters when it's raining?
No.
Helicopters are like fair weather deals. All right? So don't call for a helicopter if it's like slightly overcast, you know, because they won't fly. But heavy winds, rain, thunderstorms, you're not getting a helicopter. But you can factor that in because you know it. That's common sense stuff because you've been in the field and you've worked and you've heard the stories before. All right? Access, we went over that. Apartment complexes, house numbers, apartment numbers. Is the door open? If the door's not open, do we force entry?
No.
We need to call for an additional resource. Call for the fire department. They will be the one to gain you access into that house. Now they might ask you to form a working diagnosis off your chief complaint. Now I gave you vital signs and all that, but if you go, hey, chest pain, or you're going on a something, and they give you 6 things, and they say pick 3, all 3 of those better have chest pain in them. You don't have vital signs, but we do get a chief complaint from dispatch. All right? You got to make sure, they're going to ask you maybe the severity based off that little bit of information from dispatch. To me, those are your 2 severe calls. Like that lets me know this is probably a critical patient, maybe. If they have altered mental status or they're unconscious, that steps up my level of severity. Other than that, it's a regular call. There ain't no times 4 that they said bright red spurting blood, or they have an open leg wound that's, you know, they said they were hit by a car or like that. Like the call we went on this morning, it was an autoped, auto pedestrian. You go on an autoped, a guy hit by a bike. Now, we've had those things. I've probably gotten the last 5 autopeds. That was the most serious. The other 5 were bumped in a school line. Like, bumped in a school line. And I go, well, I'm not launching a helicopter, calling. I can't, oh, by the way, it'll ask too, like, do you want to know, like, you're going on let's say a pediatric drowning or a pediatric autoped. Do we notify the hospital based off dispatch information?
No.
Because you show up there and it might not be as bad as it is. Because they call and they go, hey, there's smoke coming from the vehicle, all that. And I'm like, it's an airbag.
Yeah.
You know what I mean? It's a radiator. A little bit of oil on the engine. It's okay. You know what I mean? It's a hot engine. Get a little oil in there, you get a little smoke, no big deal. But, I mean, they will make it sound like the worst case scenario and like that. And we never call the hospital based off dispatch information. We won't activate a STEMI or a level 1 trauma just because you say chest pain and they've had a heart attack before and the patient says they've had a heart attack before. I'm not activating a STEMI. When do I activate a STEMI? After I see the patient. That's a scene question. All right? But they might ask you severity. They might ask you, they're going to ask you crew resource management. So always choose those. Assign roles, do assignments on equipment and stuff like that, and then prioritize equipment. What are you bringing in? telling you, they're common sense questions. You just have to put yourself in that mode. Don't think about answering the way you think they want to hear it. Think about what you would do. Try to put yourself in that call and say, hey, how would I react to this? All right, so now you get to sing. I will break these down. That will be my next deal, to break these things down. But this is how you're going to treat it. You walk in, hey, life threats. Actually, I can write it down for you right now. All right, this is your operational order. Life threats. All right. Uh, all right. Good. Let me make sure I got that. All right. Life threats. I put this as major bleeds. So that's why I always put tourniquets, chest seals, wound packing. If you got it, and wound packing is for anything that's not an extremity, right? Now, it's not just bleeding. This is major bleeding. If you have a femoral artery bleed, bright red spurting blood, you could lose your whole volume in 30 to 60 seconds. You need to apply a tourniquet now, like quick, within 20 seconds. All right. You'll start, drop a knee on them, do some direct compression, stuff like that. That way it frees up your hand. But this is not stuff we overlook and do airway first. If it's got to be major bleeding. Now, if you have a laceration on your thigh and it's oozing, is that a?
Nope.
That can wait, right?
Yep.
You're just prioritizing. All right. 2, C-spine, LOC. Honestly, you really get the LOC part here. LOC is just, you're going to get it. It's not something you have to ask for or something like that. But C-spine. All right. What's the difference and words matter on this test, if I say manually stabilize the spine and completely stabilize the spine?
Your hands and your
One takes 2 seconds.
Yep.
That's manual stabilization. That's holding C-spine. Doesn't take a lot of effort. It's like, hey, hold C-spine. Whoop, done. No big deal. Completely stabilize the spine means I've already done my what? Head to toe. I've rolled them. I've looked on the back. I've done all that stuff. Checked for PMS. And now I have them hooked to a backboard with a C-collar. They're fully packaged. That happens later. You know what I mean? Initially, hey, hold C-spine. Boom, done. And that's if it's a trauma scenario. All right? Then we get to airway. I will tell you this about the ABC, or all these steps. You cannot move on to the other until you address what number you're on. Cannot move on to airway until you address life threats. There's no life threats to address? Move down. Do I need to hold C-spine? No, move down. Airway. Is there an airway issue? So I'm going to do a whole airway sounds chart, and I'm going to do upper and lower. The upper part are things we address right there. So stridor, gurgling, snoring. That's what we address in the airway part. So those are what you address right then and there. Stridor, gurgling, snoring. Then we move on to breathing. After you address you got a good airway, you move on to breathing. Breathing is when you decide, do we need to oxygenate or ventilate? And we'll go through a whole chart on that. All right, and then 5 is circulation. If there is other bleeding, we've addressed air, we've addressed breathing, and there is some bleeding, then we do direct pressure. And if the direct pressure doesn't work, if you're bleeding through, you get a tourniquet. Maybe you didn't catch it, you know what I mean? But it may be like a venous bleed, and you're like, I can't get this thing to stop bleeding. Usually direct pressure will stop it, or you do some kind of pressure bandage. It doesn't work, move on to a tourniquet. But hopefully you caught the tourniquet need up here in the life threats. All right. Now, you go through this operational order, and then you start forming a working diagnosis. That's more like a scene question, where I give you signs and symptoms, chief complaint, vital signs, and history and meds. Now, I'll say this. Just because somebody has a history of diabetes does not mean we are there for a diabetic issue. It's a clue. You know what I mean? 80% of the country has like diabetes, type 2 or type 1. Mostly type 2. Okay? They're taking some kind of diabetic, Mounjaro or any other list of diabetic medications. All right? It does not mean you're there for diabetes. It's just a part of the puzzle. You have to put it together. All right? Just because they have a history of an MI doesn't mean we're there for an MI. All right? But you look at all this, and you start forming a working diagnosis. Again, what's most likely, least likely, likely. All right? And then we get into management and treatment. What we need to do on scene. For your run-of-the-mill patient that is not critical, do what you would normally do. Can we do an IV on scene?
Yeah.
And a scene can mean in the back of the ambulance. All right? We just haven't left yet. Once we leave, now we're post-scene. So, if you can manage them right there, give the medication they need, do it. We give the pain medication there. We give the IV there. All that stuff is all encompassed within scene. All right? So, do all your treatment. Like, if it's a STEMI, and they meet the, like I can give nitro, or I can give aspirin. Yeah, you're gonna do that right there. If you got someone with a broke arm from a fall, yeah, give them pain management right there. All right, so you can do that stuff on scene. Don't let a shot of diesel be your primary treatment. Do what you can. Definitely manage those things up here in the operational order, and then manage the other things if it's a non-critical patient. Just sit there and go, hey, can I stabilize them like that before I mobilize them? Yeah. All right. Like Ross patients, by the way, RSI, do you know what RSI stands for? There is not a fucking thing about it that's rapid. And I'm just being honest. It's never been rapid. Then they start calling it delayed. Now they call it resuscitative, the sequence intubation. It's why? Because you need to stabilize them before you do RSI. You need to get their oxygen up to 94. You need to get their volume, their pressure up to 90 or 100. Now, how do we do that? We give them fluids, give them pressors. How do we do that? We give them oxygenation. We give them the nitrogen washout. We give them all that stuff. Give them PEEP if we're bagging them or doing CPAP. Do all these things to increase them because, think about it, when somebody needs RSI, cliffhanger, they're hanging by fingertips. All their sympathetic nervous system, all the catecholamines, all their stuff is working to live as best they can. We're hanging on by a thread. What happens when you give sedation and paralytics? So we have to, you just take all the catecholamines, you're blocking the sympathetic nervous system. All that stuff they're hanging on by, if you don't build them up before you put them down, it's going to be a clean kill. It really is. All right? Once we taught that to our department, one of the FTOs sat there and goes, "Oh my God, it's like my 3 last CPR saves, I've caused it." Because they put somebody down that was 82% breathing difficulty, 82%, and they were hypotensive and hypoxic. And she goes, "I'm the one that killed him." It's like, yeah, but you got it back, but we call it a clean kill, We didn't know this stuff. I probably did have a couple of clean kills on my book, you know what I mean? But until we learned this stuff, it's like, oh, we need to resuscitate them, stabilize them before we do procedures. All right? But do that management, treatment on scene. Post-scene, response to treatment. Your patient will either get better or they're going to either improve or get worse. All right? Like that head injury dude, he's A&O times 4. You get him in the back. Everything looks good. Vitals don't look anything. Nothing's pointing a different way. And what does he start? And the way in the back, it's a head bleed, starts having a seizure. You see signs of ICP, all this other stuff. And it's like, hey, now we pivot. What do? You got to start treating a little bit different. You know what I mean? Now we start bagging them. And now we do a little mild hyperventilation to bring down his CO2. And I'll go through that when we talk about that. But you got to pivot and make a change. If you sit there and treated the guy for an MI, and then he goes into cardiac arrest. Now we're dealing with cardiac arrest. Pivot. Make that change. Do that treatment. Like that. Now, if it's you and one other guy transported to the hospital, this has been in a scenario before. You're transporting an MI, and it says he codes on you. Don't tell your partner to step on the gas, because who's only back there? One person. Can you do CPR, breathe for somebody? You may think you can. You may think you're Superman, and you can do all the things. You can't. So the answer is, have your partner pull over, get in the back and help. And now we've pivoted back to kind of route. We're going to call for some additional resources. So you may need some additional resources here because the patient condition deteriorated. You need somebody else back there. All right. This one's always the hard one for you. Hospital choice. They're going to give you 2 to 3 choices. All right. They're going to say a general hospital is here, a comprehensive hospital, trauma center. They'll give you 3 choices. You make the choice based off the patient's condition. What's the best thing? All right. So a general hospital. Who lives somewhere remote where there's just a little podunk hospital? All right. What's the hospital name?
Hill Regional.
Huh?
Hill Regional.
Hill Regional. That is a general, what we would establish as it would be labeled as a general hospital. Now, a general hospital, if you have let's say you have an airway issue with a patient. Let's say you're working at Hill County EMS, and you're treating a patient, and you're about to take a patient you're like, I'm going to take them all the way to Mansfield Methodist because they are a stroke. And let's say the patient deteriorates, and you don't have airway protocols where you can put them down and all this other stuff. And you're like, well, what do? You divert to the general hospital. They can take care of airway issues. They can crack somebody. They can do emergency airway procedures. Any hospital can do that. I don't care if they're podunk or not. They have the equipment to do general advanced airway procedures, whether that's intubation, cric, surgical cric, whatever. But if you don't have that equipment, you divert to the closest hospital, even though you were headed to the hospital they need, right? To the stroke center. All right. Now, cardiac arrest, any hospital can take a cardiac arrest. So they can handle cardiac arrest and advanced airway procedures. All right. Now, do you want to take, if you're in Hill County, your closest trauma center is going to be Waco, right? Is that right?
Oh, yes.
Close hospital, Waco, 30 minutes. Well, let's say they're on trauma divert, and your closest hospital now is Dallas, Methodist Dallas, and that's an hour away. And you go, major trauma, do you want to roll that into a general hospital? Unless they need airway stabilization, no. That's when you might call for a flight. Say, hey, you need to fly that patient out. That's when you sit there and make that transport mode choice. Hey, flight, or ambulance. All right? They're going to give you the time of day. They're going to give you traffic and all that other stuff. Now, you get into the trauma levels of a hospital. Do you know what those mean? Or you think you have an idea? Level 1 trauma, so any burn center is always going to be a level 1 trauma. So if it says burn center, just assume it's a level 1. All right? Level 1's a teaching hospital. It's a major trauma. The level 1 can handle anything. There's not much difference between a level 1 and level 2. Level 2 just may not have some of the services on site, but they can be called in if you do a trauma activation. Like if we do a trauma activation, we have 2 level 2 hospitals. If we do a trauma activation during the day, that just means they come down from they meet us in the ER. If we do a trauma activation at 3 o'clock at night, they have 30 minutes. That's why early notification is good. But you have to have patient information. Can't do it from dispatch information. But we will try to notify them as quick as we can. We're coming in with a level 1 trauma because they can wake them up and then they have to be within 30 minutes, those services. So they will get a trauma surgeon in there within 30 minutes. And they will be on call or whatever. But they have all the same services. It might just not be on site 24/7. So level 2 can handle level 1 trauma. We take all our level 1 traumas there. We used to go to MCP, like that. Honestly, there's not much difference between a level 2 and a level 3. Level 3, same thing. Just might be less services that need to be called in. They might not have surgery capabilities on site 24/7. They can call those in. General surgeons, trauma surgeons, whatever. They can call those in. They have to recruit those resources and have them working for the hospital to be a level. That's like level 3, they have to get all that stuff. All right? Level 4 is pretty close to your general hospital. They can handle some trauma, not much. So if you're looking for a big delineation, level 3 to level 4 has a big gap. Level 1 to level 3 is actually a real small gap. Because we went through the level 3 deals with our hospitals, and then the level 2s. Like we have Centennial, they're Baylor Centennial, they're a level 3. Baylor McKinney and McKinney, Medical City McKinney, they're both level 2. Now, we will try to divert to the higher level of care if we're close, but if we had a trauma that was pretty good and it was right next to Centennial, we're not driving all the way across town. We got to have a good reason to. You know what I mean? It needs to be a for sure level 1 trauma, and we'll take it there. Otherwise, we can still take it to Centennial, and they'll transfer it out. They'll stabilize, transfer it out. They might can do some stuff. But it's just the level of resources at the hospital. Traffic. Patient's critical. We need to get to the hospital quick. Just got to factor that in. All right? Just because it sounds critical doesn't mean it is critical. All right? So make it based off your assessment findings. Don't play the what-if game. If you have an MI and the general hospital is 15 minutes away, and they say the hospital with PCI capabilities or percutaneous interventions, which just means it has a cath lab, but they can handle it. They're a chest pain center. And like that is 30 minutes away, take them to that level of care. All right? But make it based off your diagnosis specialty. That would be trauma, cath lab. Do you know the difference between a comprehensive and a primary stroke center? Primary stroke center, they can do TPA, thrombolytics. They can sometimes do the fishhook retrieval, stuff like that. They'll go in through the cath and do the retrieval of the deal. They can do some of that stuff. Comprehensive, they can do brain surgery. So comprehensive can do everything. It's like a level 1, and a primary can do some of the stuff. They can diagnose. They have the CTs. They can do the scans. They can do all that stuff. I'm telling you this because you kind of got to know this stuff when you're making the hospital decision. But you make it based off the intel you have. Just because the dude's having chest pain, but you're not seeing anything on the 12 lead, and you're sitting there going, well, I probably need, let's say it's a 23-year-old with chest pain. I don't know. Let's say he's what do you call them dudes in the octagon? MMA. Say he's fighting, and he's stretched or whatever, and it looks like a stretched muscle or, got hit in the chest, and he's having chest pain. You're not seeing anything on the 12 lead. He has no history to back up that we've been having an MI. He's got no drug use to say, like, hey, maybe he's doing some coke before or something like that. Nothing is pointing towards this patient is going to have an MI. Do you need to take that dude to the cath lab? No. You can take him to a general hall. You can take him to the closest available. That's how you, if you got nothing to match with it, it's like, and I know we do a lot of stuff to CYA, cover our ass, and I hate this about, because if you work in the Metroplex, you don't have to make a lot of decisions, because everybody's getting their trauma designations, everybody's getting their cath lab, they've been working on it for years, and now they haven't. It's like, shit, it doesn't matter. Doesn't matter for me and McKinney. I know I'm going to take them there. All right? The only real decision our guys have to make is, we have 2 pediatric hospitals, one in Plano, one in Prosper, and they only handle medical patients. So if it's a trauma kid, less than 14, that's the only scenario that we really have to make a decision if we're going to fly them or whatever to get them to medical, children's medical, because that's our closest children's trauma center. All right? All right. You've taken it a couple times. How many times have you taken it before?
The registry, yeah, 3 times.
Would you not agree?
Oh, yeah, yeah, that's accurate.
That's how it goes. Is there
Give you the
anything?
time of the day too,
Yeah.
on the transport route.
Yeah, they'll give you time of day. All right. I'll write the scenarios out because I'll have to do it on a whole board one day, maybe at the beginning of the next day or something like that. But like, just to give you examples, you're going to a 19-year-old that's screaming and combative in the middle of the park. What resources do you want?
PD.
There you go. You know what I mean? Like, some of the stuff is real easy. Yeah. Hey, it's good lighting. It's in the middle of the day. I can see him. You know, he's in the middle of the park. So really, just have PD take care of it and bring him to me. Make sure he's secure, stuff like that. If it sounds like a weapon or anything, don't approach the scene. Just don't. All right. All right. Other than that, we're going to get into the operational order. Do y'all need a break?
Yes.
Yeah. Get some coffee, get something. I'm actually really good about it today. That's the first time I've done a break on time. If you think you need a break, and I'm really ignore people when they start walking out, just say, hey, can we get a break real quick? And I'll go, okay. Because once I get into it, I just keep going. And I apologize for that.
Yeah, I only walked out because my boyfriend brought me coffee.
Little 7 brew.
Yeah, it's important.
Is that the? I think that's the one my husband likes to go to.
Yeah, it's
They have
good.
a pink drink.
Yeah, kind of. Well, they have pink drinks are from Starbucks.
I think she does both.
Yeah,
I can't remember the names.
7 Brew's cheaper.
It's the one out there on the right side of 77 if you're going out of town.
Yeah, the one right next to First Watch
Is
or
that where
something.
you go?
Yeah.
You know him?
Huh?
Garrett? You know any of their names?
Mm-hmm.
One of the guys that used to play golf with my son. He's a senior at Mayfield.
Hmm?
He works out there.
Yeah, I wish I knew more people out here. I just don't know them very much.
Where do you work?
I work up at CareFlight in Dallas.
Okay.
I'm trying to get out of Dallas.
You do transfers?
Yeah, I've been doing transfers for like 3 years.
Okay.
I'm kind of over it.
I don't mind you. It's a good experience, huh?
Yeah, it taught me how to talk.
I've had students that they freak out on, like, some people are just not comfortable talking to patients, like talking to a stranger.
Hmm?
Oh, yeah, it's like, I said, if you just treat them like any other person and just go, hey, what's up? Like, don't think you have to be proper medical.
No.
Like, hey, what's going on?
Yeah, I mean, that's what I did in my write-outs. My instructor, he was like, yeah, I didn't even have to bother you about your confidence. You just went up and started talking. I'm like,
Yeah.
it's
It's
all,
like, you have information, I need it.
gimme.
Yeah.
Hand it over now.
I gotta ask questions to get that information. So like, let's just go. You know what I mean? My big deal is when the patient, I get frustrated. It's like, patient won't talk to me, and I'm like, okay. I was like, you called me. I didn't call you.
Mm-hmm.
I was like, help me out here. Let's work together on this. And it's like, let's work together.
I have a question. How do you guys know when you're cleared to take a registry?
They haven't sent out the email yet saying that we're cleared to do so.
Okay.
Yeah.
You could create an application now.
Yeah.
It's not all problems. You should put an NRE on it.
Huh? Yeah.
You pick your location. Thank you. Oh, that's for Hillsborough. Hill College? It's like 20 minutes from now.
Pearsonville can have a lot of locations. Usually Hill College is not one of them.
Before we can get the voucher code, we have to have post completion, like all your clinical stuff is done. He's gonna give us the code.
Did any of you guys like actually use the paper you wrote on? Because I looked at it once.
I used a little bit of it.
I didn't use a single thing. I feel like they did not even look at it.
I
think I looked at it on one way. It was the ad for just because.
Oh, dude, when I wrote that down, I was like,
It was
yes.
8.
I was like, yes, I wrote it down.
It was 8, right?
Yeah.
I got 8.
I got 8.
Cool.
There was one where it was good, I wrote down the pediatric,
Apgar?
take the pacing,
Oh, yeah.
or the cardio version.
I wrote that.
And it's 0.5 then 1.
It's 10, y'all picked 10 to 20, right?
Yeah.
10 to 20?
Yeah.
I'm doing it right now.
I, what I do?
Because it's 0.5 to 1
Yeah, it
per
is.
kilo.
Yeah.
Right?
I know, I had information
He was
about,
40, he was 40 kilos.
yeah.
So it'd be 20.
I had information about wolves on there, so I'm glad I wrote that down, because there's at least one wolf question.
Oh, I did not. I had.
Yeah, there's, yeah, there's at least one. You also,
Can't use it anything with.
It will want to be big.
Yeah.
you also can't. get
Sheldon told me to research on that.
Eddie?
Hey,
Yeah, Eddie.
Yeah, don't listen to that guy.
Who's that?
He's a paramedic guy.
Oh, what?
He's fired for a reason. Don't listen to that guy.
Yeah, nurse now.
What's the nurse do?
The nurse called him a wee driver.
Oh, what?
He called him there,
Were you
yeah.
there when this happened?
No, I mean, I was there during it.
Did you know about that?
Oh, no, I didn't know about that. So maybe about.
Yeah.
Once you're final, we can't find yet.
Sam.
Let's say complete.
Sam. Were you in the bus like 2 weeks ago? Driving in there? 2 weeks ago?
Maybe.
I thought I seen you.
Where was it at?
It was right like where you, if you're gonna go on what's that road called? It's whenever you're like coming from Italy.
Oh, it was definitely.
Yeah. And you're going towards Frost.
Yeah.
Yeah. I seen you driving in there.
Who do you work for?
Elisa, down
Here.
in Italy.
Oh, okay, so you're Ellis County? Y'all don't do, I talked to y'all's guy, I don't know, is your region guy?
Chad. Is it Chad or Mike?
There's 2 of them.
Is he older looking or is he younger?
He was wearing a vest. Is he a vest guy?
I think it's Mike.
Gray, it was gray hair.
Mike.
He's talking about y'all are looking at, or y'all getting into the helicopter business too?
Mm-hmm.
The other one, I can't remember what his job was. Anyway, I met him because I was at a Baylor event in McKinney. But they're talking about getting blood, and we do blood. And
Really?
I was showing them some of our cooler and the apps and stuff we use and all the other stuff. But I was like, if you want to do it down here in Ellis County, I said, I'm a huge supporter because I am from Ellis County. I live in Ellis County. I know everybody, or especially Waxahachie. I'm like, I'm all for it. Yeah, I was like, let's do it. And I said, I will help you with whatever you need down here to do that. I didn't know that Maypearl wasn't a full-time station.
No, for whatever reason.
Yeah.
I
You
found that
got
out.
3 trucks, huh?
So I found that out.
Did you get a wreck in Maypearl?
We usually make her at night. Oh, you're in
Oh, you do?
Yeah.
Where do y'all, are y'all out of the fire station?
Yeah, he just hired.
Okay. Hey, is that Taco Real still there?
Yeah.
Yeah, it's good stuff. Little street tacos. The other thing I would give you, but I would say watch the pit. There is a.
Asthmatic kid.
Yes. No, and they threw the kitchen.
Yeah.
So like, if you have a kid, severe asthma attack, any kind of bronchoconstrictive condition, All right, I'll go through this when we do airway stuff. But the big deal with once they get to severe respiratory distress, and especially with asthma, number one, don't put them on CPAP. You're gonna kill them. Bag them if it gets severe. Another thing is throw the kitchen sink at them. So what people don't realize, like you get to the point where you're like, no lower lung sounds, you're almost silent chest, they're air trapping. Their inhalation is 4 times longer than their exhalation, and they're air trapping, and all this stuff's getting way worse. And I explained this to the guys last night, how it progresses, it gets worse. I don't just go, hey, epi, then I do this, and then I do, epi, and then I do AA, and then I do tubulin, then I do mag. I go, no. I was like, one guy's doing epi on one shoulder, I'm doing tubulin, the other guy's setting up an A&A, and if we need to bag it in, we're bagging it in, the other guy's working on IV, and we're going to do mag. I'm throwing the kitchen sink at you all at once. Because what I need to do, reverse that bronchoconstriction, best I can. Now, I can't get that A&A down until I get those meds in. But I can start it, but I can sit there and do that while, hey, you give epi, because epi can work pretty quick. And then I give tubulin. It's a sub-Q shot. And then somebody starts IV and do mag. Mag's a smooth muscle relaxant. Relieves bronchoconstriction. All right? So I'm doing all this at once, not itemized separately. Does that make sense? But you need to think about this test is also least invasive to most invasive.
BLS before ALS.
BLS before ALS, but when you think about least invasive means I can give it real quick. So if you were to think of your chest pain, you learn MONA, right? MONA is not the correct order. Morphine's the last thing. Or pain management's the last thing. So think about it like this. Oxygen. That's the quickest thing I can do if they need it. It's literally here, do it, like that. Honestly, aspirin is probably the quickest thing. But oxygen, aspirin, nitro, because I can do sublingual tabs, like that. And then morphine, that's why it's the most invasive because I have to start an IV to give it. Or fentanyl, some kind of pain management. All right, but you have to think about that. Think about least invasive to most invasive. I lost the train of thought. I was going to do. But I got 3 of my initial national registry questions, and you may think, hey, 3 questions is 3 questions. I got it off the show ER. That was like the pit back then. Had 20 seasons or something. Same guy. No, yeah, Dr. Wiley and all that. Changed his name. But back then, they were going, I got the question for universal donor of blood. Had no idea. Everybody's pretty good with that now, but like, who's the universal donor? It's O negative. And I was sitting there going, racking my brain. I was like, what is it? O, A, B, O, and I go, wait, hold on. They're always hollering for blood in that show. Yeah. And I was like, what do they say? Give me 3 units of 2, or 2 units of 2 units of O neg. And I go, okay, O negative. That's the answer. Then they did something for had ICP or spinal swelling for a spinal injury or something like that. And they said, and I recognized the drug off the TV show, I said, they said, what's something you would give they said, what's something you would give for this? It's an osmotic diuretic. And I go, I can whittle down what an osmotic diuretic is. And I go, well, they always give it for the spinal and the brain injuries. And I go, what is it? And it was, I can't even remember right now. It starts with the M. But it's something they do in the hospital, not on the ambulance. And then I think I got one more question off the deal. You know what I mean? But if you pay attention to those medical shows, great. If you're going to relax and watch TV in between studying, watch a medical TV show. And especially the PIT, because that will give you so much signs and symptoms. They're like that. They're going through there. It's like, hey, they got end-of-life DNR issues. They got just about everything. Junctional tourniquets. They had the MCI. They got impalements. All kinds of good stuff. I'm just saying, every time I watch it, I go, that's national registry. That's national registry. I at least pick up 3 or 4 on each episode. So, if you're going to relax and watch TV, you might as well watch the PIT. and prepare for the National Registry.
The osmotic diuretic is.
Mannitol. Mannitol. As soon as you started saying it, I was like, yep, mannitol. Alright, so now we've gotten past the life threats, now we're going to airway. Alright, so when you're stabilizing airway, this is, what did I say is going to be your upper airway, right?
Yes.
Not your lower airway. Lower airway, we take care of that in the breathing portion, and the oxygenation portion. So, your upper airway sounds are, what are they again?
Snoring.
Strider,
Gargling.
gurgling,
Snoring.
snoring. Alright? We'll go least invasive to most invasive. Snoring. What causes snoring? It's a tongue obstruction. This is the most overlooked thing in securing an airway on your chest by all of y'all. Because you get this sexy scenario and they're unconscious, they got thrown from a vehicle and give you all these vital signs and all this other stuff, and it says, hey, there's no life threats to address, but the patient's critical, and what are you going to do next? You do the airway, right? And it says you're holding C-spine, there's no tourniquets or chest seals that need to be done, but you know the patient's critical, so what do you do? And the patient's unconscious with snoring respirations. That's an A problem. We got to take care of it. All right? So, when we do snoring, we put the patients in two categories: trauma and medical. Now, if they're a trauma patient, what's one way to fix snoring? It's an airway adjustment. No, trauma. We do the jaw thrust because they could have what? Now, I said trauma with C-spine injuries. We're going to do a jaw thrust. You can do a head tilt on somebody with a, broken femur. You know what I mean? But usually jaw thrust, and then what would be another way?
Opiate.
OPA, MPA. That's our way around the tongue. An OPA or MPA. Medically, we do the head tilt. And then we can also do OPA, MPA. Nice and easy. You just have to be looking for it when you're reading the scenario. If they tell you they're unconscious, that's a big deal. They tell you altered mental status. If they say responsive to pain, you need to register that in your head. That's the altered mental status. It's probably a critical patient. All right. They're trying to give you the level. Just can't go vital signs only. You got to do how they present. Every little sign or symptom, just register it and say, okay, I know they're unconscious or they're responsive to pain, which are altered. Paint that picture in your head of what that patient looks like. And try to gain like, hey, this is critical. And then they give you the vital signs. Don't just go to the vital signs. All right? Gurgling. What is that? Fluid in the upper airway. All right? What's our fix?
Suction.
How long? It's a trick question. Until it's clear. All right? Now, if that means I have to plant that suction catheter in there the whole time until I secure that airway. Now, if I'm suctioning and I suction for 10 seconds and it's still filling with blood or some kind of fluid, what do I need to do? This is where I might need to step up my airway management, right? And I probably need to RSI and put them down. That's a patient you need to take down because I can't secure their airway. All right? Now, if they're bleeding, like let's say there's some kind of trauma, like impaled object or something, deal like that. If they're bleeding and they're conscious and they're able to talk or something like that and they just keep, let's say they're vomiting blood, you got an upper GI bleed, and they're sitting there like this and they're like that, yeah, I can let them sit there for a minute and just hold their head up like that. I don't have to lay them on their back. But if I'm unable to stop the bleed, which they had that in the pit, if I'm unable to stop the bleed, there comes a decision where I gotta go, okay, you're bleeding a lot and you're throwing up blood, this could become an airway issue. And I was like, I might need to take your airway. You have to make that decision because, it just comes down to it where you can't sit there and let them just, because number one, they're losing blood. If they're losing blood, they're losing oxygen, right? So you have to make a decision on when to do it. But if they're laying there like that, I had a guy, it was on the news, I don't know. Guy's coming down the stairs, him and his wife got in a fight. She's like 4'11" at the bottom of the stairs. He pulls out a gun. He said he pulled out a gun and it just fired. Shot her right in the mouth, right through the backside. Bleeding everywhere. And he goes, there's just blood everywhere. I can't remember if she was in cardiac arrest initially, but she was right there, and then she went into it. And I walk in, he said, I want you to get in that airway. And I go, okay, cool. I go over there, and I was like, give me, he's like, I keep suctioning like that. I said, give me the suction. I just planted it in there. I go, you stay there until I get the airway secured. Just keep suctioning. It's okay. You can keep doing it. Most of the time, you ever heard of SALAD technique? Suction assisted laryngeotracheal airway?
Right there.
Yeah. You just plant it, and I intubate around it. We do it all the time. So the 10 seconds on the way out, what you don't see in the fine print in the book is you really suction till it's gone. All right, so suction till gone. All right, Strider. What is Strider?
Narrowing.
Narrowing. Upper airway due to swelling or an object. We're going to look at these 5 conditions. All right. Number 1, epiglottitis. 2, croup. 3, anaphylaxis. 4, burn. Last, foreign body airway obstruction. All right. Before I do that, I know they're going to do. We're going to have done an artist. Big chin. Alright, so this is your oropharynx, oropharynx, nasopharynx, goes back to that's your whole encompassing pharynx, and then it drops down to the larynx. The larynx is where the cords are, that's your voice box. Alright, the larynx is where the epiglottis lives. The epiglottis drops down over the cords, the glottic opening, whenever you swallow, right? So it moves every time you swallow, and then your esophagus runs down the backside all the way down here to your stomach. Once you get below the glottic opening, now you're into the trachea, protected by the tracheal rings. Tracheal rings are open in the back, right? Back towards that esophagus. And then you get down here to the bronchus, the main stem, you get to your lungs. You got 3 lobes on the right, 2 lobes on the left, and it encompasses the heart, right? Okay, so look at something like epiglottitis. It's a bacterial infection. other Epilogue. This is what's happening. Usually it's a kid deal, it's gonna be an adult deal. Alright? Now, every time you swallow, it moves, right? Have you ever had a ingrown toenail? Ingrown fingernail? You know what I'm talking about? One of those where you grab you reach for a handle or something, you hit it, you're like, God dang it, that hurts. You know what I'm talking about? Or every time you push on that, yeah, it just hurts. It's infected, it hurts like a son of a bitch. That's what happens here. Every time they swallow, it moves and it fucking hurts. So what do they not want to do? Swallow. So, what do? And they get in tripod position. By the way, everybody gets short of breath, gets in tripod position. You go run sprints, what do? Here. And coach says, hey, stand up. Put your hands over your head. Hands over your head does nothing. What he doesn't want you to do is this. That closes your airway. This is what everybody does when they're short of breath. If they're sitting at the house, they get up to the edge and they sit like this, and they're trying to draw more air in. It's a natural defense mechanism that your body has to draw in more air, right? So tripoding, everybody does it when they're short of breath. So that's it's a good thing to see. I can tell how short of breath you are if you're tripoding, but that just lets me know that you're short of breath. Other than that, no big deal. All right? So they're going to be sitting there, and I want you to think about how much concentration it would be to let all the saliva that is produced in your mouth just fall out. Like you're mentally retarded or got palsy or something, and you just letting it fall out. And I'm being serious. Like, have you ever tried to drool? No, you can't make yourself, you can't sit there, you just be like, oh, that's gross. You know what I mean? Like, just a drool and let it come out. Like, maybe if you had that tequila shot and you got that watery taste in your mouth and you're like, ah, you keep spitting, but you're not drooling. All right? That's a fucking sick kid. You're going to see that right off the bat. That is a really, really sick kid. This is a urgent condition, critical condition. All right? This is not your kid's short of breath or has a cough or a sore throat. This is like a really, really sick kid. Doesn't happen that often. All right? So, you get this. It's infectious, bacterial infection. So they're going to have a fever? Yeah. Are they going to have stridor? Yeah. They're going to have drooling. Those are your 3 key signs and symptoms for epiglottitis. Fever, stridor, drooling. You may say drooling and you think of stroke. Does stroke have a fever? No. Just like I tell you, pneumonia has decreased breath sounds on one side. Does that mean they have a pneumo developing? No, they have a fever. You know what I mean? Fever's a big deal in this test. So fever, stridor, drooling. All right. Now, what's our fix going to be for this epiglottitis? One, this is my only way to help remember that, is keep calm and chive on. Keep them calm. Whatever makes them calm. Do not aggravate this kid. Do not stick anything in his throat. Do not get this kid riled up. If it's a toy, if it's a caregiver, if it's something, just keep them calm. If you suspect this, just keep them calm. Now, I will give you a treatment that you can do, but y'all think it's something else. Have you ever heard of that?
Yes.
What is racemic epi?
And nebulized.
Does not mean nebulized epi. It is given nebulized, but it does not mean nebulized epi. Racemic does not mean nebulized. Racemic is a certain brand of epinephrine that costs a lot more, and it doesn't have the beta-1 effects, so it doesn't get them heart rate riled up. That's it. It's a Highland Park epi that doesn't get your heart rate up. You know what I mean? It costs a lot more, and it doesn't do certain things. But what it does is it vasoconstricts. What you need here is vasoconstriction. Epi is more of an airway drug than it is a cardiac drug. All right? Think about it like this. Have you ever rolled your ankle? What'd you put on it? Why? Huh? I know. What is it?
Constriction of the blood vessels.
It reduces swelling by constricting the blood vessels because that's how they respond to cold. Yeah? You ever get out in the cold? What does it do? Keeps the core warm, but your arms get all that, hair stands up, your arms are cold, it shunts everything to keep the good organs, warm, to maintain your body heat. But your arms get cold, you know what I mean? But that's what ice does. Epi is like ice for the airway. It's not gonna, you think about it, it's swollen, infected, you need an antibiotic, but it can reduce a little bit of swelling without getting them riled up. And you nebulize it, just like that. Nebulized epi is just nebulized epi. But you're gonna get the beta 1 effects. Like, we do that for croup. Yep, we do. Nebulized epi works great for croup. Gave my daughter nebulized epi, it flipped her around like nobody's business. And you know what? 5 minutes later, she's jumping on the bed and just blah, blah, blah. Because what did it do? Give her pure adrenaline and jacked up her heart rate. Now she's ready to go play, you know what I mean? She went from sick to like, hey, let's jump so many times we can jump on the hospital bed. I'm like, okay. But if you did have racemic epi as a choice, you could do that for epiglottitis. Because you could get some of the vasoconstrictive properties without the increased heart rate. Basically, you're not riling them up, but you want to keep them calm. I think most of the time they're going to ask you to recognize it. All right, now, what if it had completely occluded their glycogen? What's the next step?
Iron.
Think about the worst procedure that you ever want to do in your life.
Right.
If the bridge is out, we got to go around. Just like if you had a foreign body airway obstruction that you couldn't remove, what do? Crank them. Again, things you would learn if you watch The Pivot. All right? No, but they do a lot of cranks. But you crank them. All right? Now, I will tell you this. The decision to do a crank is one of the easiest decisions you'll ever do in your life. The procedure is not. It's scary, whatever. But on this test, if you have Strider, it becomes completely occluded, whether it's foreign body airway obstruction, epiglottitis, or something like that, and it says they're no longer moving air, you got to crack them. All right? Croup. This is what croup looks like. I'll just do a side picture. This is their phlotic opening, and this is their trachea, before it splits off. Croup is diagnosed through signs and symptoms, but is also they diagnose with an X-ray. Croup is a subglottic swelling. It's a viral issue. Viral issue, we don't have, if it's bacterial, we give antibiotics, right? If it's viral, we treat signs and symptoms. We don't have a lot of antivirals. So this is one way to look. We call this the steeple airway. See, it comes to a point like a steeple on a perch. And then this one, another way to present, and this is the hourglass look. Now, I told you it's viral. It's infectious. Is there going to be a fever?
Yes.
The answer, there's one. Fever and Strider. It's in the Strider section. Yeah. Now, big deal with them is a dead giveaway is a steel bark cough. All right. Here's what happens.
It really does sound like that.
Yes, it really does. They will call it a croupy cough. The bad part about it is you need to write down the other name for croup because that's how it's going to be presented on national registry. It's laryngeo tracheo bronchitis. You will miss it if you're looking for croup. Laryngeo. There. I'm gonna try this. Yeah, I'm from Ellis County. Laryngeo tracheo.
Yeah, I already saw it.
It's 2 words. All right. Tell me this. If you look at where the swelling is, this is where the bifurcation, your carina is, right? Where the bronchus, main stem bronchus, like that. This is where the swelling is at. All right. Where did I say your voice box is at? The glottic opening. It's in the larynx, right? What's below the larynx? Your trachea. And it runs down to your bronchus. That's why it's laryngeo tracheal bronchitis. It's because of where the swelling is. Basically 3 separate areas. all in one. So if that helps you remember, it's laryngeal tracheobronchitis, that's where the swelling's at. Now, I mentioned this earlier, and I said bronchoconstrictive condition, or just airway constrictive conditions. All right. Accessory muscle use. You've seen it, right?
Yeah.
Where it's sinking in around the clavicle, stuff like that. So picture like, I take a deep breath in, no, nothing constricting me, no accessory muscle use. Now like do it through your teeth. See how you're pulling in, you're sucking in around the muscles, your accessory muscles, and you're pulling in down here like a little JVD and like pulling. It's almost like you're lifting, you know what I mean? Like everything's stretched out. Like that's what it's like to breathe with a constrictive condition. Their I to E is going to be real high. Have you ever heard about I to E? Your inhalation to exhalation ratio. So anybody with a constrictive airway condition or constrictive or restrictive airway condition is always going to have a longer inhalation to their exhalation. Now, I breathe normal. I take a deep breath in. I get plenty of oxygen. I get my 21%. I got a good reserve because I'm breathing normal. After a while, what these people are, they're not getting full oxygenation, so they're having to take longer inhalations. And then they get the respiratory centers, your pons and medulla in your brain, right? Your pons and medulla are sitting there going, hey, you didn't get enough air. We need to make sure our inhalations are longer than our exhalations. So it becomes like a 4-to-1 ratio. So any asthma, any kind of restrictive condition, they will ask on National Registry. They say, what's longer? It's always the inhalation is longer. The I to E, it's like when you do a ventilator settings, you guys set the I to E. The inhalation setting, the inhalation is always going to be longer than the exhalation with any restrictive or constrictive airway condition. Because they're going to be trying to get as much as they can, but they only got about 30% of what they usually get. And then they breathe out and they go, oh, I didn't get enough air that time. I go, and I start sucking back in again. And that's what makes these hard for these kids to breathe. All right. Now, with the constrictive condition due to the airway swelling, what happens is we call it air traffic because their inhalation is longer than their exhalation. It's not matching up, right? It's not a 4-to-4, it's a 4-to-1. So you get a lot of air trapped down here. If you got a lot of air trapped down here, you can't breathe out that CO2, right? You got some O2 going across, but the CO2 is not coming back out. So you're having a buildup of CO2. And then your body says, hey, we need to get rid of that. So it produces a forceful cough. This is infected, it's dry, and that's why it comes out like a seal bark cough. Like it's a dry cough. So they're like, essentially they're auto-relieving the pressure, buildup of pressure, the buildup of the air trapped down there. So once it gets trapped and expanded enough, they're like, hey, we got to get rid of it. And then they go, and they build it and they get it out.
Like a pee kind of valve?
Yes, a relief valve.
Yeah.
Think like a relief valve. So you'll hit that relief valve. They're not coughing like that 24/7. It's once the pressure builds up, then they have to relieve it. So it's like a relief valve. And then they get that dry cough, and that's the dead giveaway. You can walk into the house and you hear that, and they're like, okay, we got a croupy cough. We know what it is. It happens during cold and flu season. All right, now, always happens during cold and flu season. Temperature changes stuff. It's usually cold outside. What do? Outside, let them breathe. Let them breathe that cold air. Open a door. Let them get some of that cold air. At home, how many got kids?
Freezer.
Got croup? They commit their croup
I
yet?
was actually about to ask if I could show a video. 911 was already on the way, but my son woke up struggling to breathe and he had croup, so I was going to play how it sounded.
Yes,
It
play
was
it.
pretty bad.
Put his head in the freezer. Try it.
He was like struggling at this
How old?
point. He was 2 at this time. But it was bad.
How was he pulling? He tugging? Like
Mhm.
all that stuff?
Yeah, his oxygen was like almost in the 70s at that point.
All right. So, cold air works great.
And it was in November.
Yeah. I took my daughter out 3 times. Once we went to the hospital. And I take her out in the cold, she started breathing a little bit easier. Vasoconstriction helps with the vessels. That helps with the swelling. I put her head in the freezer. Do not give these kids a warm shower. You think because it's dry, they need moisture. Now you can do humidified oxygen with them, but you do not do warm. Because how do vessels respond to warm? They dilate. It makes the swelling worse. So, whereas the moisture from a hot shower might help, the heat does not help. It makes it worse. Putting their head in the freezer sounds stupid. Breathing in cold air, it helps. So cold air helps, but the one thing we do is nebulize epi. Again, we're looking for the vasoconstriction. Now, here's another thing that you can do, add in, but I would say don't ever make this your frontline treatment for breathing difficulty. You can throw in a corticosteroid. Solumedrol, something like that. Everybody will tell you Solumedrol takes 2 hours to work. I can tell you Solumedrol can work in 20 minutes, it can work in 40 minutes, it can work in 60 minutes, it can work in 2 hours. The deal is how fast you metabolize it. If you metabolize it fast, or you get it on, it can work a lot quicker. And if it's a kid, usually it can work a little bit quicker because the metabolism's up. All right. So if you metabolize it quicker, it can work a little more effective. Problem is, you probably won't see the effects of it until you're at the hospital like that. But it's a good thing to get on board, but it's not my front line. It's the nuts or the cherry on the sundae. You know what I mean? It's not the ice cream scoop. If I'm making a banana split, it's not the banana slices. It's not the ice cream scoops. It's not the hot fudge. It's the cherry at the end. You know what I mean? I know it makes it better, but it's not the main course. You know what I mean? So, do that, you give breathing steroid. Does everybody know how steroid works? Or what it does? The corticosteroid. So, how many of y'all go to a different part of Texas or somewhere, a different state, and boom, allergies kick up? For me, West Texas. I played college baseball out there. Every time I was in Dallas for a little bit, like I was home for, say in the summer, I was home for a couple weeks, and I go back out there, I would just have to take the Zyrtec. All right? So, here's what happens. If you look at your airway is meant to protect your lungs. All right? So, let's say, here's your airway. You have all these hairs, cilia. All these hairs inside your airway, and they are meant to sweep up any foreign pathogens that get in there. Its goal is to protect these guys. We don't want to get in there because we don't want to, you might get an upper respiratory tract that turns in, we don't want to turn into pneumonia, stuff like that. We don't want foreign pathogens in there. Now, along your tract, you have these squamous cells. They're a little square, thin wall, like that. When you get introduced to a foreign pathogen, all right, you work for fire, right? Been to a fire? Anybody been to fire academy and did burns? Were you snotty the next couple of days?
Yes, sir.
Because you were introduced to a foreign pathogen. Cyanide, all that kind of bad shit. Alright, here's how your body protects itself. This is your immune response. These squamous cells turn into Coliver cells. Think of it as like a tube of toothpaste. They go from here to here. And what they do is they drop a little bit of mucus in the airway. That mucus is meant to catch the pathogen, and then your cilia is meant to sweep it up. That's why you get snotty, you cough up stuff. Get that junk. What you're trying to do is get it before it gets to the lungs and just cough it all up, right? That is your immune system working. Now, once all this mucus gets in your airway, does it make it? Yeah. So it makes it harder to breathe, right? Harder to take in air. You've been there, you've had allergies, it's like you're snotting all the time, you're like, you can't take in a good breath, all that. That is just your immune system doing its job. How do you make it easier to breathe? Is one of the ways is to suppress your immune system. That is what steroids do. Corticosteroids suppress your immune system. By suppressing, this goes all the way through to your bronchi, bronchioles, and stuff like that. Its job is to suppress that, which opens up the airway and makes it easier for you to breathe. It just takes time. Corticosteroids take time, 20 minutes, something like that. But it reduces airway inflammation that is caused by your immune system. that make sense? So, when you suppress people that take chronic corticosteroids, guess what? It's easier for them to get sick. You know why? Because it suppresses your immune system. You need your immune system to battle these deals. But nebulized epi, give a shot of shot of Solumedrol if you have an IV. In the hospital, they might dexamethasone, Solumedrol, Solucortef. If it's a Solu something, it's a steroid. Dexamethasone's another one. But if you're taking steroids, usually it's a breathing difficulty. So they have this question on NAS registry. Your patient takes no, it's not beta blocker. I thought it was at first, but I had to slow down and read it. Metaproterenol. And it was some kind of steroid. It looked like dexamethasone, but it was something else. But you could tell it was a steroid. It was something to zone. And I was like, okay, that's a steroid. I don't know what metaproterenol is. And there was some other drug. And they said, what does the patient have? This is one where I sat there and I go, it's probably asthma. And I go, yeah, I talked myself out of it. And you know what the other answer was that I chose? Fucking lupus. Because I go, lupus is autoimmune. Maybe they take a steroid to suppress their immune system because it's attacking healthy blood cells, healthy organs. And I was like, so I got it down to two fairly deals. But I told myself, I go, if they're taking a steroid, and I go, I just don't know what the other two drugs are. If they're taking a steroid, most likely it's a breathing deal. Like the law of, probability, more people have breathing difficulties than they do have lupus, which is autoimmune. And I talked myself out of it. I went and looked at metoprolol, and it's a inhaled bronchodilator or something. Like one of the other medicines, I was like, son of a bitch, I missed that one. All right, but I did talk myself out of it. So, nebulized epi, steroid, this is usually fix the kids right up. No big deal. Anaphylaxis. All right, what's going on? How are we going to fix anaphylaxis? Yep. So epi buys you time to get to the Benadryl. Epi takes care of the upper airway edema. Here's what happens. Like if you were to look, what's it called where the arteries and the veins come together?
Microcirculation?
Yeah. What is the area?
Capillaries.
All right. So where the capillaries come together, capillaries are what envelops your alveoli. They wrap around it. That's where you unload the oxygen to the arterial side, and then you offload the CO2, right? So if we were to look at a normal capillary, all right, so let's say this is the arterial side, this is O2 coming across, this is the venous side, and this is CO2 coming out. This is the interstitial space. This is your cell. This is a normal looking capillary. All right? What happens is the process of diffusion. Do you know what diffusion is?
Higher concentration or lower concentration?
Higher concentration, lower concentration. So, there's no students out in the hallway. There's students in this classroom. There's a higher concentration of students here than out there. So what would happen is, if I sent y'all out into the hallway through the door, I would diffuse y'all out into the hallway. Does that make sense?
Yeah.
Higher concentration, lower concentration, and then if you can do the reverse, blah, blah, blah. But that's diffusion. So higher concentration O2 on the arterial side, lower concentration O2 at the cellular level. Higher concentration of CO2 and waste because it's been working, and lower concentration here, it diffuses back across. All right? This is what happens. You get a histamine release, which causes a mast cell release, and it causes major vasodilation in the body. So here's what happens. Draw this wrong. You get massive vasodilation. You get your cell over here, and then what happens is you don't have a good gradient to cross. For a higher pressure and a lower pressure, you don't have that good gradient. So it just kind of, it'd be like if I removed this wall, and there's no real separation from the hallway in the classroom, and y'all could all just kind of hang out here, but it's no like, I can't diffuse you in and out of the deal. It's like, hey, some are here, some are there, no big deal. But the interstitial space is where everything hangs out, and that's where you get swelling at. So the interstitial space is like swelling from a burn. Third spacing, that's swelling in the interstitial space. So all the fluid gets caught here, the blood pressure drops, right? Now, that's where you get swelling in the upper airway. We do the epi first. What does the epi do? Vasoconstricts. So it helps out with the upper airway swelling, but it also helps out with what? The blood pressure. Epi lasts for how long? 5 minutes. It lasts for 5 minutes, and then what do? Now we need to give the antidote. What did I say started the whole process? A histamine release. Histamine, mast cell, vasodilation. How do we reverse that? We give an antihistamine. So that's when you give Benadryl. So everybody does anybody here have an EpiPen? You do?
Yes, sir.
Can I ask what you're allergic to?
Peanuts.
Great. I haven't had that yet. So, we'll talk about that here in just a second. So, your EpiPen, do you carry Benadryl with you?
No.
You should. Epi just buys you time to get to the Benadryl. Or call 911. So if you hit yourself with the Epi, go ahead and down the Benadryl too. You know what I mean? I don't know why. It's an IM shot. I don't know why there's not a combo for, EpiPens cost like $1,500 now. But why it's not a combo shot? Because that's the antidote. You got to take an antihistamine. You know what I mean? Because that's what's happening in your body. All right? Now, and then you could also take a steroid. Or you could take an albuterol treatment. Now, do we take albuterol treatment just because you're shortness of breath? What do we have to have?
Wheezing.
You have to have wheezing. If you don't have wheezes, you don't give albuterol. When is the only time you would be safe, without listening to lung sounds, safe to give albuterol and you know there's bronchoconstriction, but you have not listened? You can't hear it. But you know there's something that we can put on a monitor that will let me know that there is bronchoconstriction. If you get entitled with shark fin waveforms, that's as good as listening to breath sounds. We're really bad at listening to breath sounds. Breath sounds dictate our treatment. But if you see shark fin waveform, that's a good enough positive for bronchoconstriction. You can give albuterol. But we can give it. Epi fixes the upper airway, and it can assist with the bronchodilation. All right, so we get a little 2-for-1 there. We give the Benadryl. We give the steroid to kind of slow the stifle the immune system. But we can also give an ANA as well if they're having wheezing. Does that make sense? All right. Now, here's the other deal about allergic reactions you might not know. I go over this when we do the vital sign patterns, but might as well cover it here. You don't have to ingest it or touch it to have the reaction. I had a kid on my baseball team, had a big nut allergy. I told him, we played baseball. What do you have at baseball games?
Sunflower seeds.
Peanuts. They have peanuts everywhere. Hey, he can't be around the dust. If the dust hits like that, baseball games are dangerous places for you because they have
Mine's not that bad. If I had it, I'm dead, man.
This kid was severe. So the dust can hit you if there's a lot of peanut dust, because what are you doing? Breaking peanuts and stuff like that and the shells? You can have that and you can go into full anaphylaxis.
On my capstone, I had that. She had a really bad peanut allergy, and everyone knew not to have peanuts, but I guess someone opened a bag of peanuts, and it was like at 3 a.m.
Yeah.
And she had a whole huh?
You say your cat?
My capstones.
Oh.
Yeah.
I'd be crazy.
So I had to tell all the parents, because what do they do? I mean, it was back when this is like 3rd grade. Moms are bringing the after game snacks. I go, I don't want to see a fucking peanut anywhere near our team. And I had to tell him because he's got a big allergy. I was like, and I don't want to work on my off days. All right. So you don't have to touch it or ingest it to get exposed to it. Had another one at Encore Wire. It's a plant up in McKinney, a real big plant that does wire. It's a big campus, a lot of buildings, stuff like that. She had an allergy to seafood, shellfish. She's working nights. She's in the break room having a cup of coffee. The other person's coming in. They ate some Papados. They took their stuff out of the fridge. They heat it up in the microwave. What'd she just do? She vaporized it. Vaporized it. It got to that girl. She had a full allergy. They gave her 2 Epis before we even got there. Gave her 2 Epis because they called in the nurse. They have a nurse facility nurse. It's a big campus. They call in the nurse. They give 2 Epis. Call 911. We ended up giving another Epi. Gave Benadryl and gave steroid. So, got to get the Benadryl too. So start carrying Benadryl with you, just in case.
I carry Benadryl with me. I'm
Yep.
allergic to bees and wasps.
There you go.
So.
But never had full anaphylaxis?
No, I have.
Yeah.
When I was like 12,
Why don't you carry an EpiPen?
I already used it. And they're expensive.
Did you know there's multiple doses in an EpiPen?
I did not know that.
Did you know?
I didn't know that.
It's a wildland deal, wildland medicine. So the part where you stick it in like that, the top part. If you take a knife and you cut it around, now it's gonna do like a champagne cork because it's got a spring loaded. You do like that, it shoots up. You can YouTube it. It'll pop off. You can take the syringe out. It has a stopper on it. It has 2.1 milliliters of epi. Where it stops at is 0.3. So it gives you the 0.3 and it hits like a ridge inside the deal. If you take that out, the plunger out, and you reverse it, it can go past that little ridge, and you have, I think you have 6 more shots at epi, 6 or 7. I think it's 2.4.
I didn't
in
know
there.
that.
Yeah.
Next time I get my next one, I'll
You
do
have to keep
that.
stabbing them again?
Huh?
You have to keep stabbing them again, or?
Well, you still have to get the needle and shoot in 0.3, but it's a normal 3 cc syringe. So you can keep giving yourself epi until you get help.
Okay. Well,
But-
now I know. Thank you.
Yeah. So don't get rid of it just because you used it once.
I didn't know that.
Watch the video. You got a card. It's like, like open a can or something like that. Can opener, but just watch out. It's going to shoot out. You got that. So epi, Benadryl, you could in a steroid. You could do an A&A. Burns. Again, same thing. Third spacing, swelling. All right. What is going to be like if somebody's coming out of a house fire, or house on fire, they tried to put it out, they come outside, but they were inside the burning building. What would be the first visual sign you would see to let you know that this could be an airway burn? Soot or anything around the nose or mouth. That lets you know, what do you need to do first? Take a look. You need to look inside, look for swelling. All right? The other sign would be something you hear. If they say hoarse voice or something like that, soot around the nose and mouth, they're giving you 2 positives, you probably have an airway burn, and they're probably already starting to swell. You have to act quick. You got to be aggressive with this. What they're guiding you towards is you need to do rapid intubation. So RSI, this would meet the indications for RSI. You RSI them, but you need to tube them with one size smaller than what you would normally use. So if you do a 7 or a 7.5 on adult males, drop it down to a 6.5. My first fire on A shift when I came off days in July, we had a fatality fire. The guy, gas cans or something, garage, whatever. He caught fire. We thought it was like 80% burn. It ended up being 100% burn. Cops bring him right to it was back in the alley. They said, hey, there's a guy back here. Ambulance was already back there. They said, let's get him in the deal. I'm doing my 360 as a safety officer, and I go back there and I see they got a patient, and I open the doors, and both med units, they were assigned to fire back there working on the dude. And right when I open the door, they're getting ready to intubate. And I go, I'm looking at it, assessing how far burned he is. He's pretty burned up. And I just go, I was like, how's the airway? I can see her, like struggling. I go, the tough? She goes, yeah. And they end up getting with the 602. They started with the idea of a 6.5 and they go, drop it down a little bit just to be safe. They
We don't
went,
carry half size.
huh?
We don't carry half size.
Just go one size smaller, full size.
They just do a lot more trip.
Yeah, just go with the full size smaller. But the big deal is you secure an airway, right? But that is what they're guiding you towards on an airway burn, is to go one size smaller and innovate. That's the answer they're trying to get you there. Get you to that. We don't, if you hear the muffled voice or the hoarse voice or something like that, and you see the swelling is already occurring, so move fast. Make sense? All right, so ETT, one size smaller.
Can that be for like any swelling of the?
I need to take a break.
No, I should just.
All right. Is that for what?
Can that be for any swelling, like one size smaller?
Yeah, but usually you can do epi and like reverse the swelling. This one, you're not. You gotta be aggressive with your airway management. Get in there and secure the tube before it swells up. If it does, what do you do?
Which area?
Correct. So like whenever they're trying to get the innovation and she's working on it and she's like sitting there flex like that, I just threw out a little dark humor and I go, by the way, I was like, dibs on crack. I was like, I haven't done one yet. So I was like looking for that first opportunity. Hey, take 5 minutes. We'll finish this up for lunch.
Just curious, just because I need to let my boyfriend know about what time, because he has
I'm
to
gonna
partner.
try, since I'm trying to do this in 3 days,
Mhm.
I'm gonna try to run you all as close to 5 as possible every day.
Okay. Cool.
All right. I just want to make sure try to get in everything.
Yeah, no, I was just curious because he's
Yeah.
just asking, so I wanted to let him know because he has the car today. So.
Yeah. The other day, the only reason we started at 9 today is because I was coming from McKinney and our ship ends at 6:30 and I wasn't for sure I could get here on time.
Yeah.
It was a school, still got school traffic and all that.
So we're also doing the 20th, you said?
Oh, who works for Ellis County? Y'all do? How bad do you hate this time of year? Scarborough Fair.
I
Oh.
don't work in that side. so
On the
I don't
weekends?
have a problem.
I live on that road.
Oh, no you don't.
Yeah.
Where do you work, where do you live?
On 66 before Scarborough Fair.
Do you live in Waterford? What's the road? There's like one right across from you. Do you live in that neighborhood?
No, I knew before that.
Before it? You live in that single street house? Just one street that goes to the right? I guess it's after, they put all those businesses in there.
Yeah, it's after that toy old place.
You still work for ESD6?
Yeah,
So you know what it's like.
yeah.
Yeah, it's a pain in the ass.
Scarborough's okay. I work first aid over there.
Hmm?
Scarborough's okay. I work first aid over there. It's
I've lived here all my life.
Mhm.
And I have only been to that once because they offered, my 4th grade teacher worked there and gave me extra credit.
Nice.
And I did not,
Well, I couldn't think
I'm
of one
sorry,
at 20s.
blowing glass and joust and all that stuff.
Well, there's really good I like getting my honey from there because there's local honey people there. But I also get in for free, so I don't really care.
So if you want the honey set,
No.
those people are at the farmer's market every Saturday.
I go every Saturday.
But
Yeah.
you know who makes the best?
No, I don't.
It's not so bad.
Hey, what do you call those people that are not, it's like a step down from an Amish. It's like Amish people that use electricity.
Mormon?
Mennonite.
Mennonite.
The Mennonite people, they look like Amish people.
Mhm.
They make the best baked goods,
Noted.
best sweets you've ever had.
Yeah. But also, first aid actually pays quite well.
What's it called?
Like 16. That's pretty good for that's like average EMT pay for
Yeah.
working first aid for just looking at them and be like, yeah, you're good.
Like, they're dirty. carnies, and
Oh, dude, they're
they
nasty.
smell like shit. Man.
Oh, I don't.
They take a shower.
They
Dude.
sleep in the
shower on that.
They sleep in the
In that
trees.
shower.
They smoke dope and sleep in the trees.
Dude, they're nasty. Trust
I
me.
always tell everybody, I said, I always forget what time of year it is, but I said, if you're in a restaurant and you look to your right and you scan across the crowd and you see, what's the Pirates of the Caribbean guy? Jack?
Yeah.
I was like, you see a Jack Sparrow lookalike? I go, it's Renaissance Fair time.
Yeah, no, they're so nasty.
Like they were sitting outside, Tom Thumb, like, I don't know, like trying to recruit people to come down. I was just like, I can smell you from here. It's
Yeah.
so bad.
Mhm.
They travel around. Do they work the what do they do in October?
Screams.
Screams.
No,
Or not
doing,
art.
like
they're-
Autumn Fest.
They're called hollows now.
Hollows,
Yeah,
whatever. They got
something
rid of
like that.
screens.
So have
Which
you ever
sucks,
seen
by the way,
So have
just
you
so
ever
you know.
seen where they sleep up in the trees?
Ew, no.
Yeah. So if you
They
go on
sleep-
66,
they sleep- they sleep
you
in
go
the
past
trees.
Scarborough Fair, and you get to the point where you can see like the buildings have been, and then it's just the stuff behind it, you know, behind the buildings, stuff like that. Look up there, and you'll see the little what do you call it?
Hammock?
Hammocks. They'll be up there in the hammocks, and they smoke dope and live in the
Oh my
hammocks.
god.
Yeah.
We
They don't shower. They're dirty, dirty people.
They are.
we have to go out there, like walk back through their things, and I'm just like, oh my god, you
I just
guys
wish
live
that thing
like
burned
this?
To the ground.
I don't know how we haven't had a fire there.
Well,
I don't
that's
know
what's
either.
like. Well, Sashi just keeps passing it because that's what
We've had
they
more
go-
fires at the, have you ever been to, heard of Canton Third Monday, First Monday or something like that? So that's what they're known for. We have a third Monday of McKinney, and it's on 380. It's like the most valuable piece of land, and they have that cannon type deal.
Yeah.
But we have been on more fires there. Then I was like, Scarborough Fair's got to burn down one day.
I was like, I just want that place to burn down so I don't have to worry about
Really,
all
the
that.
only like places that could make a fire is where the kitchens are, and you walk into those kitchens, you're like, how is this not like a fire regulation?
But you have the-
Like,
What cracks me up is everybody from outside here, they go, "Oh, do you go to Scarborough Fair?" I'm like, "No, I don't
no.
want nothing to do with it."
Yeah, I was like, one of y'all like this is a piece of shit.
Like, and they go, or like I skated medieval times with my kids. Didn't have to go to that. I don't want to go to that. It was like medieval times. I skated Disney World, and I was like, didn't want to do that. And I was like, but just the Renaissance deal. People that are into it, they're totally into it.
Yeah.
They come.
Oh yeah, like
Our president here at the college, his daughter came through, Kate, came through EMT and medic school. She comes out the bathroom dressed one day, and I just went, "What are you doing?" And she goes, "I work part-time at Scarborough Fair." And I was like, "You're probably like the only one that bathes there." And she goes, "You really don't like it?" I said, "No, I hate it. I can't stand it." I was like, if I could,
yeah, you can see him walking to that gas station, and like like I ain't stopping there to it.
Yeah.
You want to know the most sketchy hotel in Waxahachie?
The Dallas
The
The
Inn.
one right across on 66.
That yellow one.
The Dallas
I don't know,
Inn.
the Texas Inn?
Yeah, that one.
Yeah.
Texas Inn's pretty sketchy, but
I have a story about that one.
the most sketchy one, if you go down, so 66, then you got 1446, and then your next exit is Brookside.
Oh,
You're
that
going
one
back
right
towards
there?
Dallas.
Mm-hmm.
And you always see those people walking to the Shell station. Like, I have
Oh,
never gone down that
yeah,
road
yeah.
without somebody walking back and forth.
Mm-hmm.
That is, I guarantee you, there's the most drug use, hooker stuff, prostitution, drug use, all that is happening right there in both those hotels.
Yep.
And I laugh because that's used to be where the DPS headquarters
Yes.
was. And I was like, how are you not like just cracking down on this?
Like,
It's
Like
now-
it's been known
I'm
since
pretty
like
sure it's now
high
like a
school.
probation office.
It's those two like
Yeah.
over here and that hotel over here. They're all the same. It's just
It
like,
used to be cause before we could have bars in Waxahachie, they had the they had the bar in the hotel there.
Yes.
And that's where all the
Shark
yes. My friend's mom used to go to the Shark Club.
My mom loved it.
Yeah. And she went to the Shark Club and she was like, I said, what's it like? She goes, you don't need to go in there. And she goes, I'm white trash, and I even feel uncomfortable.
They had a shark in there, like an actual shark.
I remember when I was doing delivery driving and I had a delivery to the Dallas Inn, and I'm just like this little 16-year-old girl, and I walk up and this huge black dude opens up the door and he's like butt ass naked, and I'm like, here's your delivery, and he's like, thanks, Snags, and he was like, you need to pay, and he's like, no, I don't, and he slammed the door on me, and it was like my third delivery, and I'm just like,
It used to be the big prostitution place was, do you know where,
that was the first time I
do you know where the old ETMC station is? It's called Dunkin' Plumbing now.
Yes.
It's the old Waxahachie Fire Station too, but it was the ETMC station for a long time. They used to, right there where the road split at John Arden,
Walgreens.
there used to be a place called the video station. And the video
Oh,
station,
yeah. Hey, it would turn
that's where
down.
I trade baseball cards at and everything. But the video station had a like special room in the back where you get your nasty videos, all that. But the that little motel, nothing but prostitution coming out of there. And I was just going, oh.
And now
They rent by the hour. Huh?
now it's a car wash.
Yeah.
whatever, and they'll
That's what I always tell people. They go, what do you like, what's the worst part about your job? I was like, I get to know the worst about the town.
Yeah.
It was like, you see it as like, hey, this nice little bubble, McKinney, like that. And I go, I can tell you some stuff about McKinney. You'll just be like, what?
Yeah. Like Waco.
Yeah. At Waco, you had the, what was it, the
Convenience.
Vidians, yeah. But,
It's not though. It's a chip in your eye.
no, it's the, no, they had the shootout. Where's one of the wing places where the girls dress all short shorts? Twin Peaks.
Oh.
They had the biker gang.
Costex and the
yeah.
Banditos.
Yeah, two big biker gangs. They had the big shootout there. And I was like, man, Waco's just killing it. You got the Branch Davidians, got the shootout with the biker gangs. It's like, bad stuff over there.
We got a lot of Section A housing in there.
yeah.
It's all the
A lot of it.
All right, last one. Foreign body airway obstruction. I don't write this down because you have, it's real simple, but you have 3 separate categories. You have adult, PD, infant. All right, so if they say on the test, they give you the choking sign and they're coughing, what do you do?
Choking. That was the call for it.
Say, hey, keep going, encouragement, do it. You know what I mean? Because if they're moving air, I don't need to do anything. If they're still moving air, you just encourage them to cough more, get it out. All right, now, if I give you I'm alert. I give you the universal sign for choking, I'm not moving air. What's your first action? Nope.
Not up.
Heimlich. So you do the Heimlich, 2 hands, encircling, umbilicus, and you just start cranking. When do you stop? If it's expelled, or I go limp, and I go unresponsive. Once I go unresponsive, you take 2 hands, chest, not CPR. I'm a stickler on this, because CPR is cardiopulmonary resuscitation. We don't have an airway, so I can't do the pulmonary part. Can't bag them. I just do chest compressions. So I will do chest thrusts or chest compressions, 2-handed, and I will do, say, a round of 5 or a round of 10. They don't get into the specifics on that, but usually they say 5, because you're used to the 5 back blows on the infant stuff. You do 5 chest compressions, and then you get in there and visualize. The difference between you and an EMT now is you can do they're trying to guide you towards direct laryngoscopy. So you do direct laryngoscopy, you get the Miguel's, you pull out. And now, if it is a food or object or something like that, grab it, pull it out. No big deal. Now, if it is something soft and you can't suction it out, but you could get an airway through there, intubate through it. I'm talking like pudding or soft food. We run in this a lot at the nursing homes. Like if it's bratwurst day, that was a CPR, that was PEA, and we just hauling bratwurst out. Got it out, secured the airway, we got her back. Now, I don't know if she wanted to be back. She had all kinds of medical problems. But she probably said, just leave me. But she didn't have a DNR, so we did it. The last one we did was at the country club, El Dorado Country Club, it was shrimp night, and he had some kind of esophageal constriction disease, maybe like Barrett's or something like that. They had some kind of esophageal constriction disease. He knew about it, loved shrimp. It happens. He didn't have an allergic reaction, but it can happen. He knew he was dealing with it, and usually he can clear it, just cough it up and clear it. He couldn't that night, goes into cardiac arrest. We start clearing his airway with so much shrimp, it was just coming up because we're doing the chest compressions, and we're just clearing shrimp, and then we get the tube, and then even pieces of shrimp were coming up through the tube, so we had to sit there and go, it was like coming up to the top, had to pop the top off and get the shrimp out and put the top back on and start breathing for him. So, they're trying to guide you towards direct laryngoscopy. So, two hands, get in there and look, and pull it out. The only difference between that and a pediatric is one hand. One hand, you still get in there and look. You go to the infant one. Everybody's more comfortable with the infant one because it's a 5 and 5, right? Mm-hmm. 5 back blows, 5 chest compressions, you still get in there and look. You never go blind. If you can do a direct laryngoscopy, get in there, look, get it out. That make sense?
Yes, sir.
Nice and easy. 2 hand, 1 hand, 5 and 5. But they're always going to guide you towards direct laryngoscopy now that you're a paramedic. So get in there, take a look with your handle, and pull it out. All right, let's see here. I think we're at a stopping point. All right, so let's do lunch. Be back by 1 o'clock. Everybody went to school here, so you know where stuff's at around here. I don't have to do any of that. So you either work here or you went to school here, so you know where stuff's at. And then I think we're going to go, we'll go into respiratory diseases like COPD and stuff like that. And we'll try to get all airway management ventilation done. We'll do a little bit of acidosis type stuff, and I think we'll go ahead and start the trauma deal and like some vital sign patterns and stuff like that. And we'll try to get through that today. And if we can go further, then I'll make an adjustment, maybe do some ops or something like that. Sound good?
Yes, sir.
All right.
Get out of here. 3 o'clock tonight. Is that gonna be a problem?
It's up to you.
I gotta go to work, so.
We work.
I feel like a farm deal, so we have a cell back here.
I got you.
Run, so I had to go take bids.
I got you.
So, but I'll be here Monday and Friday for whole day.
Okay.
How are you? Mr. Waller?
Yeah.
What's there to eat around here?
What do you like?
Yeah.
Anything?
If you go, right by the highway, but 77 usually where everything's at. They got McDonald's, Jack in the Box over here?
Yeah.
McDonald's,
Panera.
Jack in the Box. If you go
Chipotle,
left on the highway, go north 77. You got Chipotle, and Cane's. Try to get other fast food.
Arby's.
Wendy's.
Wingstop.
Wingstop, towards 77.
Yeah, I'd say go to you can honestly just take, if you go take it right here, it'll lead you down the service road, come back down, go behind the school here, 287 service road, just stay on that service road, and when you go down to the light, that'll be 77, take a look.
Okay.
Be Academy and all that, it's all around there.
You want anything while I'm out?
I'm good, thank you though.
Yes, sir.
That's fine. Do y'all get to do, as EMTs, do any advanced stuff?
Like,
IVs,
um,
IGELs,
Listen.
IOs?